Assalamu alaikum. In our previous video about morphology of infarction, we have talked about red infarct, white infarct, and at the end of that video, we were talking about the histological finding. We have left our discussion at the point that after inflammation, tissue proceeds towards repair. As we talked in our videos of tissue repair, that repair takes place either by regeneration or by scarring, scar formation. This phase depends upon the extent of tissue damage. In some tissues, parenchymal regeneration can occur at the periphery of infarct only when the stromal architecture is preserved, which is not spared in most of the cases. That's why most infarcts are replaced by scars. But never forget an exception to these generalizations, that is brain. Ischemic injury to CNS can never result in coagulative necrosis. It results in liquefactive necrosis. Then we have a term septic infarctis. You can remember this term as infarction plus infection. There are two ways for this to occur. Number one is in such cases where tissue is already infected, and then for some reasons like embolism takes place, which ultimately leads to infarction. Classic scenario is when infected cardiac wall vegetations embolize. The second case is if microbes enters in already necrotized tissue. Here infarction is taking place first and then infection, while in first case infection is first and then infarction happens. Whatever the sequence is, the thing that happens after it remains the same, that is conversion of infarct into an abscess. In both of these cases, with the correspondingly greater inflammatory response and then healing by organization and fibrosis rather than regeneration. In the last part of video, let's talk about scenario. See, if the vessels occlude at the apex and the organ periphery forming the base, then infarcts tend to be wedge shaped. The next is if the base is a serosal surface, then there is often an overlying fibrinous exudate. We have talked about apex and base. About lateral margins, if the lateral margins are irregular, then they are reflecting flow from adjacent vessels. In case of acute infarct, margins are typically indistinct and slightly hemorrhagic. But with the passage of time, edges become better defined by a narrow rim of hyperemia, which is reflecting inflammation. Let's see this one. It is a hemorrhagic, roughly wedge shaped pulmonary infarct, that is red infarct. This is showing us that this one is acute infarct, while this one, it is a sharply demarcated pale infarct in the spleen. This sharp demarcation is showing us that this infarct is chronic as compared to this one.